Okay, good afternoon, everyone. I think at this point, we're all pretty much used to doing these virtual conferences and commissions. So I want to thank you all again for joining us this virtual meeting of the Commission to Study Mental and Behavioral Health in Maryland. As we get closer to the end of the year, I just want to remind everyone that pursuant to the governor's executive order that established this commission, we have a year-end report, and we will very soon be starting the preparation of that report. As of today, we're a little less than 3 months away from the end of the year. I know that's shocking, as this year has both gone quickly, but it's been extremely eventful and something that I think we'll always remember. I expect that just as last year, we'll be submitting that report sometime toward the end of December to the governor. So, it's just something to keep in mind. And like I said, we'll be starting soon in that preparation process. For some time now, separately, local as well as national media has been talking about the impact of the pandemic on the mental health of our citizens. And that really serves to highlight the necessity of this commission. So as we meet today, and as you continue to meet in your subcommittees, I would like us to start focusing on recommendations that we can present to lower or eliminate the barriers to the delivery of treatment services to affected individuals and their families. I'll remind everyone that the recommendations are just that, they're recommendations. It doesn't automatically mean that they will make it into the report or that they will be adopted as policy. But I also urge everyone to approach our recommendations understanding that bigger is not always better. We want to focus on realistic steps that we can take to make changes, and in many cases, incremental change, and that sometimes those can lead to bigger changes down the road. I know that sometimes we in government have grand visions and want to accomplish a lot of things, but we need to make sure we, start with building the building blocks to get to that success. And as an homage to late Justice Ruth Bader Ginsburg, she stated that real change, enduring change, happens one step at a time. And so we want to create real and enduring change within our mental health delivery system. Now, having said all that about taking deliberate steps at a time, I'm going to contradict myself right now. I don't want us to shy away, though, from taking bold action or making recommendations that could be considered controversial, particularly if they need to be made to address challenges right now. One area to be considered, and I've already referred it over to the Public Safety and Justice Subcommittee, is assisted outpatient treatment, something that we should think about. And if we have time today, we can have maybe an introduction of that to some of the committee members who are not as familiar with it. Other areas to possibly consider is getting a finer definition or clarification on what it means to be a risk to oneself or others. That is often the standard that is used for determining whether a person needs to have some type of commitment. And often that means an imminent risk. And maybe it would be helpful, and I know it's going to be difficult for us to come up with the definition, but maybe we can come up with some guidelines so that our behavioral health professionals can work through a better definition so that there's some consistency with regard to how that is determined. And there may be other areas in the future that may come to mind and come out of the different committees that we should consider, but those were just two that came to mind. So moving on to today's agenda, in addition to our usual member introductions and subcommittee updates, We have a couple of special presentations during today's meeting, including a briefing from the governor's challenge to present service member, veteran, and family suicide, Ask the Question campaign. Joining us for this afternoon is Joy Ashcraft, Director of the Maryland's Commitment to Veterans, as well as Dana Burl, Director of Outreach and Advocacy Programs for the Department of Veterans Affairs. Together, they lead the governor's challenge to prevent service member, veteran, and family suicide. And I want to thank them for joining us today. We also will be hearing from John Miller, CEO of the MidAtlantic Business Group on Health, and Henry Harbin, National Healthcare Consultant and Mental Health Association of Maryland board member, for their presentation, The Path Forward for Mental Health and Substance Use. We will follow that up with, of course, our public testimony portion of the meeting. And just as a reminder for those who are the public who are tuning into this, that we're asking presenters to limit their comments to 2 minutes. I was gonna say 20 minutes, 2 minutes each, so that we can keep things moving along. And you can always feel free to provide more information or comments by emailing to our staff here using the email address mbh.commission@maryland.gov. That is also the email to sign up to testify this afternoon. So with that, I'd like to get started with the meeting. And before we get to the subcommittee reports, can we just go around there's no longer going around the table, go around the computer screen and introduce ourselves, that being the members of the commission. Okay, I'll call on someone. Carrie, maybe Carrie Cho, you can introduce yourself.
Sure. Hello, everyone. I'm Carrie Guthrie Cho, and I'm the president and CEO of Cornerstone Montgomery, a behavioral health nonprofit in Montgomery County. I'm so glad to be here today.
Thank you.
Hi, I'm Dr. Linda Beneski. I am a co-chair with Senator Hester on the Public Safety Criminal Justice Subcommittee. I'm glad to be here too.
Thank you.
Hi, I'm Senator Katie Hester. I'm Linda Beneski's co-chair on the Public Health and Safety Subcommittee. I represent District 9, Howard, and Carroll County.
Hi, Addie Eckert, Senate for District 37, Dorchester, Caroline, Wycomico, and Talbot counties.
Hello, I'm Dr. Rao Tribernini. I'm a child psychiatrist and I'm an associate medical director at MidAtlantic Kaiser Permanente.
Steve Hsu, executive director of the Opioid Operational Command Center.
Hi, Aaliyah Jones, Deputy Secretary of Behavioral Health Administration, MDH.
Hi, Serena Eckwood with NAMI.
Hi, I'm Pat Medashevsky. I'm a family advocate and I'm a registered nurse.
Hi, this is Delegate Ariana Kelly. I am sorry I don't have my video on today. We have a little bit of chaos in my house. We had a flood, but I represent district. I know it's terrible, but I am here and happy to be here. Represent District 16 in the Maryland General Assembly on the Healthcare Committee.
The joys of home ownership. Okay. Thank you.
I'll go next because I also had a flood yesterday, Delegate Kelly. This is Christian Mealy, Deputy Secretary of Disabilities and Co-Chair of the Youth and Families Subcommittee. So if I go dark as well, it's because I've got Len the plumber on the way. So
I feel so much less alone, Christian. Thank you.
Glad we could commiserate.
Hello, good afternoon. Delegate Karen Lewis Young. I represent District 3A, which is Frederick, and I'm also on Health and Government Operations.
Good afternoon, Tiffany Rexford, Acting Assistant Deputy Secretary for Programs for the Maryland Department of Human Services.
Hi, Lieutenant Governor. This is Dennis Schrader, Chief Operating Officer at the Department of Health. I've been detailed to play a major role in the COVID, and in my absence, we have Assistant Medicaid Director, newly promoted, Trish Roddy, and she's been stepping in for me as the co-chair of the Finance Committee. So I thank her for her effort.
Thank you.
Hi, this is Barbara Allen. I'm the Executive Director of James Place. I serve as the co-chair of the Behavioral Health Advisory Council, and I chair the Howard County Opioid Crisis Community Council here too.
Okay.
Hi, this is Joy Hatchett. I'm here this afternoon on behalf of Insurance Commissioner Kathleen Borain, and we co-chair the Finance Subcommittee with the Department of Health.
Hi, this is Mary Gable. I am Assistant State Superintendent with the Maryland State Department of Education in the area of student services, academic enrichment, and educational policy. Thank you.
Thank you.
Hi, this is Rich Abbott. I'm Director of Juvenile Family Services for the Maryland Judiciary, and I represent the Maryland Judiciary on the Commission.
Thank you, Richard.
Hi, this is Kimber Watts. I'm an Assistant Public Defender in our Forensic Mental Health Division. Happy to be here today. Thank you.
Okay. Is Roland Butler on the line? Major Butler?
Good afternoon, Lieutenant Colonel Roland Butler, Chief of the Maryland State Police Field Operations Bureau.
Okay, thank you, sir. Okay, if we can then move on to the subcommittee reports, crisis services.
Good afternoon, everyone, and thank you, Lieutenant Governor, for your continued focus on issues related to mental and behavioral health, even as we face some other very significant public health challenges in our state. And also, on behalf of the Opioid Operational Command Center, I want to thank everyone on this call for your interest in behavioral health and in the work of this commission. Today, I'd like to provide an update on the activities of the Commission's Crisis Services Subcommittee. As we've discussed in previous meetings, the Crisis Services Subcommittee has a standing goal of developing a comprehensive crisis coordination system, something that the pandemic has only made more urgent. The OOCC's second quarter report was released on September 22nd. The report outlines increases in total intoxication deaths of over 9% during the first half of this year as compared to the first half of last year. And within those alarming trends is an acceleration in the number of fatalities on a quarter-over-quarter basis. During the first 3 months of the year, January, February, March, fatalities were up about 1%. But during the second quarter, April, May, and June, they were up 18%. The report also outlines significant increases in intoxication deaths related to both opioid substances, but also non-opioid substances like cocaine and alcohol. When we look at objective realities like those presented in the report, it becomes crystal clear that now more than ever before, we need a robust crisis coordination system that serves the needs of Marylanders in every corner of our state. Our colleagues at the Maryland Department of Health's Behavioral Health Administration have been leading the charge to expand crisis services, and they're planning to convene an advisory group made up of subject matter experts from state government and the private sector. The Crisis Services Subcommittee has been reviewing recently the standards for organizing assertive community treatment teams, or ACT teams, which are a means of providing evidence-based interventions for people with severe mental illness. The teams are multidisciplinary and meet every day to monitor their patients' progress and to identify individual needs. These teams are available 24/7 as first-line evaluators, assisting vulnerable Marylanders in crisis. The ACT team model has demonstrated success in ensuring that high-level care is delivered to patients in a cost-effective manner. The classic ACT team model requires that the teams serve densely populated areas with a critical mass of patients, but we see merit in exploring how the model might be adjusted to suit better the needs of the entire state, including our underserved rural areas. In the coming months, our subcommittee will examine the possibility of implementing the ACT team concept throughout Maryland. Exploration of a concept like the ACT teams is a perfect example of the work that the Crisis Services Subcommittee can do to broaden the services that Maryland provides with only a modest investment. During our last meeting, the Governor's Office of Crime Prevention, Youth, and Victim Services provided an update on the establishment of the Crisis Intervention Team Center of Excellence. The Center of Excellence will provide technical guidance for developing and implementing a model crisis intervention program to local governments, law enforcement and public safety agencies, behavioral health agencies, and crisis services providers. Our next Crisis Services Subcommittee meeting will be held on November 4th at 10:30 a.m. During that meeting, we will hear an update from the Health Services Cost Review Commission on their Regional Catalyst Grants Program, which will provide considerable funding to build out the crisis response system in several regions of the state. Additionally, the Maryland Medicaid Administration will provide a briefing on their pilot program to utilize the state's outpatient mental health clinic infrastructure to expand crisis stabilization centers. More detail and login information are available on the Lieutenant Governor's website under the Mental Health Commission tab. To conclude, thank you again for your continued commitment to these issues and for your collaboration. The OOCC is always here to help, so please contact us at help.oocc@maryland.gov if we can be of assistance. Back to you, Lieutenant Governor.
Well, thanks, Steve. When you were talking about the ACT teams, they operate 7 days a week, 24 hours a day?
I'll defer to Dr. Jones on the nitty-gritty of ACT teams.
The ACT teams are available whenever patients need services. However, their typical operating hours are normal business hours. However, if a patient is in crisis and shows up in an emergency room or has a crisis at home, they have 24-hour access to someone from the team. There's always someone who's available to provide crisis management. Okay. But it's not like the locations themselves are not open 24 hours a day.
Okay. Can a family member call, when you're saying that they have access 24 hours, can a family member call where it's their family member, adult family member is in crisis?
So yes, if you're a member of the ACT team get support from those who the person lives with, typically family members, neighbors, friends, whoever has the closest relationship with that person. And so if they are noticing that that their family member or the person who's a part of the ACT team is in a crisis or has a need, they also typically have access to the ACT team as well.
Okay.
But the ACT teams they have such high touch with patients. They see them typically once a week. Someone from the team sees them once a week. It's not unusual for someone to be seen more than once a week, particularly if they are decompensating or recompensating, regardless of where they might be in their behavioral health process. So it's typically not usually necessary for someone else to reach out to them because the team has such a good handle on that person, and they can increase their accessibility, availability if the person needs a greater impact or a greater touch at a particular time. Carrie, did you want to say something?
I just wanted to throw out a resource because ACT is a wonderful model. Cornerstone Montgomery has 2 ACT teams, but it's also really expensive to start one up because you have to hire all the staff before, or at least half of the staff before you start seeing patients and bring them in. So it just takes some time. But there are resources. I know, the state is obviously looking at resources, but I also know SAMHSA often has grants, particularly for ACT development. They're very interested in ACT as well. And they had a grant last year, and it's my understanding they're going to have grants in the near future again. So just something to be aware of if we're looking at expanding that in the state. Agencies can apply for those resources. We were able to get a SAMHSA grant, and that funded the beginning of our second ACT team. We couldn't have done it otherwise. So it's definitely a resource to think about.
Yeah, and it's an evidence-based practice that's designed for the severely and persistently mentally ill person, not for the average individual. It's not an inexpensive model because it uses a lot of resources. It's highly personalized behavioral health support for the person who is constantly in and out of the hospital. That's for whom it's designed. And it was originally founded out of Case Western Reserve University, which is not an urban environment, at least not when the model originated. And actually the ACT model was designed, came to be in a rural setting, and we've adapted it to an urban setting. And actually, if we look at the way that it's reimbursed and the way that it's staffed, it's actually staffed more for rural environments than it is for urban environments, given the challenges of managing a severely and persistently mentally ill person in an urban setting. The needs are not the same. The crises are not the same. The level of aggression and violence that you see in an inner city area are not the same. And so in an urban area, quite frankly, it's more expensive to run an ACT model, but you don't get paid anymore to do it. So it's designed, it works very well and for rural settings for which it was originally, well, at least that's the way the model was originally designed. So, and it hasn't changed.
I have an elementary question. You said compensate and decompensate. What do you mean by that?
When someone starts exhibiting symptoms and starts becoming unstable. So the decompensation is
decompensation?
Yeah. And the compensation is the stabilization. Pardon me for.
Okay. No, that's all right. I'm learning. Okay. Youth and Families Subcommittee. Christian, is that going to be you?
Yeah, sorry, just had to unmute, sorry.
Okay.
Good afternoon again, Lieutenant Governor and colleagues. Our last subcommittee meeting was held on September 14th, and that was our first meeting with our new co-chair, Tiffany Rexroad, and it was a very productive meeting. We also had Delegate Kelly join us, and so we decided as a subcommittee that we're going to be meeting the second Monday every other month, so we just went to a standing meeting model. Just that seemed to work better for everybody rather than sending out a doodle poll every 6 weeks. So we also decided that to focus our efforts, and I also wanted to thank Mark Nugent from your office, Lieutenant Governor, for helping our subcommittee, our new co-chair, get a better understanding of our charge, and he also helped us sort of refine our focus. So thank you, Mark. I think you're on the line. So what we did was we ended up breaking up our subcommittee into different work groups to focus on different issues, because our strategy going forward in light of fiscal realities and light of the pandemic and its challenges, we're going to try to be a little bit more creative in our policy recommendations and solutions that we develop. So we developed 3 different work groups. One will be focused on licensure and reciprocity issues. So this group specifically will be looking at regulatory reform and rules surrounding licensure and reciprocity to see if Maryland can become a little bit more flexible now amid the COVID epidemic, and then hopefully beyond as well. I think COVID is revealing a number of things that we probably previously thought we couldn't do, but now it shows we can.
Right.
We also formed a work group that's going to be looking at and assessing Maryland's behavioral health report card, which was not stellar. So the group's going to be looking at our rating, and specifically the imminent risk law and language, as well as strengthening training efforts around this law. I think that there are improvements that doubtless can be made in that area. And then, of course, we also have our substance use services for youth and adolescents work group, and they're going to be looking at, as the title indicates, services for youth and adolescents, Medicaid reimbursement for some of these service and other state models. We're thinking about possibly adding a few more groups to cover school services and adult caregivers. And these groups are currently meeting right now, and our next meeting is November 9th. So they'll be prepared to report out to the full subcommittee on November 9th. That meeting is going to be from 1 to 3 p.m. on Google Meets. And during that meeting, we're also going to have 2 presenters from MSDE who are going to be discussing the state recovery plan, as well as a special focus on social emotional learning in a virtual world. So we're excited for that presentation as well. And I think that's about all I have. So thanks again to your staff for their continued support of the subcommittee's work.
Okay. Well, thank you. And thank you for at least in picking up on that behavioral health scorecard. That was, for those who were unaware, we, the state of Maryland, were rated an F. I guess from my days in school, F is not good. So, unless they've changed the scale, that was not good. And a couple of the things that they mentioned included, as Kristen, you said you were looking at, and that is the, definitions of, being a harm definition, a harm to themselves or others, is one of the things we were criticized about. Okay. Dennis, did you want to talk about the Finance Committee?
I was going to ask Trisha Roddy. Trish, were you going to report in today for us? Did we lose Trish? You may be muted.
There, you're still muted. Oh, there she's popping up. You're unmuted, but you're not speaking.
Sometimes both the device and the machine are muted.
She's not shown as muted. Heather is on controlling this. Check to see.
Trish, I can see that you're speaking, but no one can hear your
Right.
volume.
Is your computer muted, Trish? Well, Trish, we can try to come back to you since we're not hearing you.
Yeah, maybe if we could get Joy Hatchett to report, and Trish just texted me. She's going to call back in.
Okay. Joy? Okay, there she is.
Sure. Just a couple of things. We continue to work on the network adequacy regulations, and that includes the adequacy of the mental health providers, since there's so many questions and issues regarding to having a sufficient number of in-network mental health providers. So we continue to work on those. And also we are developing regulations related to the reporting obligations on mental health parity. Those are things that we're continuing to work on, and we will definitely be able to have something to report out and include in the end of year report this year.
All right, thank you.
This is Trisha. Can you hear me now?
There she is, yes.
Oh, great. Good. Sorry about that. I apologize. I don't know what happened there. So hopefully I don't repeat anything that Joy just mentioned. But we did meet. The subcommittee got together on September 21st. We have our next meeting that's scheduled November 4th. And we took the opportunity at the September 21st meeting, because of all the stakeholder comments that occurred at the August Commission meeting around our support of the psych IMD waivers in Maryland, we took the opportunity to spend time with the finance subcommittee, and we walked them through the history of our of when we've gotten IMD waivers in Maryland. And so just real quickly to kind of go over the highlights of that history. We had originally applied for an IMD waiver starting back in 1997, and we had one in place until 2006. And the reason why that we got rid of it at that point is we were told by CMS that they would no longer support psych IND waivers, and they required us to phase it out. So it was completely phased out by 2006. At the same time, when the Affordable Care Act, they had monies in there that allowed states to apply for an emergency psychiatric demonstration program. And Maryland was one of the states that was selected for the program. And that ran from 2012 to 2015. There was some questionable evaluation results that HHS presented on the program to Congress. And so at that point, they elected not to move forward or continue with the demonstration. Maryland, however, still put a request in from CMS, and we asked them to actively deny us or approve us. And unfortunately, they did deny us in 2015, and they said it did not align with their policy at the time. So we do have an IMD coverage for the SUD population, and that's been in place now. And we expanded that to allow us to cover individuals with a primary SUD diagnosis in a psych IMD. And we have that coverage and that ability to bill for those services now since 2018. And we talked with the subcommittee that our 1115 waiver comes up for renewal next year. We'll have to, we do have to reapply and renew it starting June and July of next year, so that we can have it in effect January 1st of 2022. And we talked to them that we would be considering putting this ask back into that renewal process. And assuming that CMS doesn't change its policy and continues to support these types of waivers, then we would expect to have this type of waiver into effect, again, January 1st of 2022. So that was a great discussion that we had over that. And then secondly, just to keep you updated, we didn't have a meeting on a behavioral health system of care process since we last met, but we do have one scheduled October 28th at 1 p.m. So we'll continue to update you on those discussions.
Okay.
And that's it.
Well, thank you. Our public safety and justice system update.
Thank you, Lieutenant Governor. At our last commission hearing, we mentioned that we had received a grant in the form of technical assistance from SAMHSA to allow us to do a state summit on the SIM model here in Maryland, followed by a training of trainers. And since that commission meeting, we've met twice as a subcommittee to basically start our planning going forward with the Consultant Policy Research Associates. And we've scheduled the summit to take place on Tuesday, November 17th and Wednesday, November 18th. And a save the date should be going out fairly soon. In our preparations, we've spoken to the forensic director of Michigan, Dr. Deborah Pinals, because they're the one state that's kind of done this so far, one of two states that's done this so far. And it was a really interesting conversation that our subcommittee was very grateful to have. We also have heard from some local examples, including Catherine Dilley, the executive director of Midshore Behavioral Health, and Belinda Frankel, the forensic mental health program manager on Midshore's experience with SIM. So we do have some local experience that we're building on. And so just to recap briefly, the goal of the State SIM Summit will be to bring together, those of us on the call, leaders, stakeholders, with three goals. First, to facilitate discussions to identify the resources and gaps and opportunities at each intercept. Second, to hold some county work groups to identify local opportunities to strengthen those existing efforts. And three, to compile recommendations informed by those discussions and outline kind of a report for the next state. So this report will be very helpful for our group in submitting our recommendations to the overall commission's report at the end of the year. We're delighted that the Lieutenant Governor, you confirmed to be a guest speaker for us, keynote speaker on the first day. And we're also currently looking for other people who have case studies of best practice anywhere along the SIM model who want to join us. So we're also established a list of outreach of about 100 different groups of participants, folks in health, behavioral health, criminal justice, lived experience, and support services. And so if anybody has recommendations for folks who really ought to participate in this State SIM Summit, please contact our office. Our next subcommittee meeting is October 20th, which is a Tuesday from 3 to 4:30. And we will continue planning around the State SIM Summit, but we'll also be discussing assisted outpatient treatment per the Lieutenant Governor's suggestion. And we hope to hear about a pilot that's been conducted in Baltimore. We'll be inviting the Maryland Outpatient Civil Commitment Program, which ran the Baltimore City pilot, to share the outcomes of their program. And if anybody's particularly interested in this and would like to either join the conversation or contribute to the conversation, once again, please look at the Commission's page, and our meeting contact information for October 20th should be posted there shortly. And I'd just like to thank again my co-chair, Dr. Linda Mineski, for her help, and my other subcommittee folks. They've really done a lot behind the scenes to get ready for this summit. And so with that, I'll give it back to you, Lieutenant Governor. Thank you so much.
Okay, thank you. Before we go to the presentations, I want to ask, because the last meeting, we did not approve the minutes from the June 23rd meeting. So we have two sets of minutes to approve, and that's the August 25th and the June 23rd. Did everyone get a copy of those minutes? Does anyone have any questions or amendments? And I guess we need to approve them separately to, I guess, be in conformity with some rules of order, Robert's Rules of Order. Is there a motion to approve the June 23rd minutes?
So moved.
Second out there?
I'll second.
Okay. Any comments? All in favor?
Aye.
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 Okay. Any not in favor? Okay, so approved. Do we have a motion for the August 25th minutes?
So moved. Second.
All right. Any, are all in favor to vote for those in favor?
Aye.
Aye.
Any opposed? Okay, well, thank you. All right, at this point, we have the briefing from the Governor's Challenge to Prevent Service Member, Veteran, and Family Suicide, Ask the Question campaign. Joy Ashcraft and Dana Burl are on the line. I saw them. I see Dana. I saw Joy Ashcraft a while ago. I have to keep them around. Maybe
I'm still here, sir.
Okay. I think, well, yeah, there you are. There are two screens, at least on my computer, there are two screens. And so I'll turn it over to you all.
Great, thank you. First, I want to thank you, Lieutenant Governor and Commissioners, for allowing Dana and I to brief you today on the Governor's Challenge and our Ask the Question campaign. We're really excited about the work we're doing. Dana's going to share our presentation with you all. So I am the Director of Maryland's Commitment to Veterans. I'm under the Behavioral Health Administration in Maryland Department of Health. So it's great to see Dr. Jones on here. So with that, Dana, can you hit the next slide? So why are we here? So as we all know, suicide is a national health concern. We are working across sectors in Maryland to really look at reducing suicide rates across all populations, but our team is specifically looking at the service member, veteran, and their family populations. So as far as Maryland statistics are concerned, while our numbers may sound low, averaging 105 deaths per year over 2015 to 2018, they do account for a much larger percentage of the deaths in our state because this population represents 9% of our adult population, whereas those suicide deaths among those who have served are 17.4%. So it is a much larger percentage of the population. As well, while typically our largest number of veteran suicide deaths are in the 80 years and older population, if you are looking in the news, while the numbers are higher, the rates are much higher among the 18 to 30-year-old population in our military members. In Maryland as well, it's majority male, non-Hispanic white, as well as firearms tends to be the method of choice. And that is across the United States, not just in Maryland. The rates among our service members and veteran population are very high for usage of firearms. So let's talk a little bit about the Governor's Challenge background. So this is a partnership, a national partnership between Big VA and and SAMHSA. And it was originally created as a mayor's challenge in 2018 and then expanded to a governor's challenge. We are now one of 27 states who have signed on to be part of the challenge. Next slide. So what we've done is really convene an interagency group that consists of military, state and federal government, nonprofits in our state, and really looking at how do we understand the issues surrounding this population, what makes them unique when we're looking at the overall suicide issue, and looking at trying to find ways to implement promising and best practices that are evidence-based that have been utilized in other states. Next slide, please. This is kind of gives you a snapshot of our team. So you can see that we're very well represented across many sectors, including state government, universities, nonprofits, the military space. Just kind of give you a broad look at our team. Next slide. Our plan. So we're really focusing on 4 priority areas that were part of the national VA suicide plan. So we are focusing on identifying our service members, veterans, and their families. While this doesn't sound like a difficult task, it really is when we're looking at the breadth of our military population in Maryland, because we have all 5 branches, National Guard and reserves in our state. And our veteran population is rather large as well. And families can be tricky as far as identifying them. So we really want to focus on trying to identify this population and screen for suicide risk. Another area is promoting connectedness and improving care transitions. So when you're looking at this population, it's not just transition from the military to civilian life. You're also looking at transitions during deployment cycle. You're looking at transitions from hospital care. We have military and veterans that have been incarcerated, so transitioning from incarceration to civilian world. So we're kind of looking at those things and including the family in that, because every transition has an impact on the family as well. Increasing lethal means safety and safety planning with a specific focus on utilizing those best practices within the VA. Because when you're looking at safety planning, this population is very unique. So you want to be able to incorporate those cultural uniqueness in safety planning when you're working with them. And expanding and specializing peer-to-peer service coordination, we have a really strong peer-to-peer program in Maryland, focused on substance use and mental health. However, we are looking at trying to add an additional accreditation so that people can specialize in being veteran military peers. And now Dana.
Good afternoon. Thank you, Lieutenant Governor, for the opportunity to present to you this afternoon. As Joy has just talked about the Governor's Challenge, I'm going to talk for the next couple of minutes about Maryland's Ask the Question campaign. I serve full-time as the Director of Outreach and Advocacy for the Maryland Department of Veterans Affairs. Behavioral health is an issue that is very near and dear to my heart. I served almost 10 years working in case management and local adult corrections, and prior to that working with adolescents, and was a former military spouse to a combat veteran. So this is both a very personal issue for me as well as one that I want to help support across the state professionally. So before I talk about the approach as it relates to the Ask the Question campaign, I just wanted to share some data with the group. What do we know as it relates to Maryland's service member, veteran, and family population? As you can see there on the slide, we have just shy of 390,000 veterans, approximately 30,000 active duty service members, a large cohort of reservists and National Guard members. We have over 100,000 veteran households with children and about 60,000 Reserve, National Guard, and active duty dependents. The real key here in this slide, and one that I work diligently to address, is that only about 40% of veterans who call Maryland home are enrolled in the VA healthcare system. Now, that could be for a variety of different reasons. It could be because they are utilizing private health insurance. It could be because they feel disenfranchised and they've made the choice not to go to the VA for whatever reason. Or it could just be that they don't know that they are eligible for VA healthcare. Another really profound statistic is that nationally, approximately 40% of veterans lost to suicide are not enrolled in the VA healthcare system. So the hypotheses with our Ask the Question campaign is that if we can encourage and enroll more veterans in VA, we can work towards driving down that suicide rate for veterans who might be calling Maryland home. As Joy already indicated, veterans represent about 17% of all deaths by suicide in the state. However, across the adult population, veterans only represent about 9%. VA just released a statistic indicating that veterans who are currently being seen for depression at the VA is seeing a decreasing rate of suicide. So there, again, the hypothesis, enroll more in VA and reduce that rate. So what we know is that before we can connect and prevent, we have to be able to identify those who have served. And the good news is that there are other states who have already implemented similar initiatives to Maryland's Ask the Question campaign. Joy and I have had opportunities to meet virtually both with New Hampshire as well as Virginia, and to learn from Connecticut. They have all previously managed pilot Ask the Question campaigns. We've been able to glean really great information about their successes and to learn from the challenges that they experienced as well. There's a marked number of or degree of work that's being done within the state. The Governor's Customer Service Initiative, this is very much in alignment with that. If we can identify more service members, veterans, and families and get them engaged in care, we are providing better customer service. We also have the Governor's Commission on Suicide Prevention that is doing very similar work to the work that we're doing within the challenge. So there's opportunities to work collaboratively together. We also have the Veteran Services Specialist Program in state government, which has been existent since 2017, where there are liaisons within all state agencies who kind of serve as a hub for veteran-related information. We can utilize those liaisons as supporters as well. And we have Joy and her team with Maryland's commitment to veterans. So the idea behind the Ask the Question campaign is that we must be able to meet service members, veterans, and families where they live, where they work, and where they thrive. And I like to share a little tidbit of I guess, information related to this slide. These are all pictures taking place in Maryland. So in terms of our approach to the Maryland's Ask the Question campaign, there's three kind of tenets to the approach. The first one is we have to make sure that we are asking the question when we are coming into contact with our consumers, with our customers. We want to ask them, have you or a loved one ever served in the military? One of the biggest barriers to service members, veterans, dependents, in terms of access to services within the community is that they don't feel understood. If we're able to ask the question and also train up service providers on military cultural competency and on VA related resources, that is going to ideally promote understanding and help to bridge that barrier when it comes to feeling misunderstood within this particular population. And we also want to ensure that we are providing to those service providers the tools that they need in order to be able to refer service members, veterans, and their families to appropriate resources when they identify that they have served. We're taking on a 3-pillar approach. We've come up with 3 essentially service provider populations that we want to pilot this campaign within. And these pillars are based on what we've learned that other states are doing. The first one is law enforcement in the justice system. We want to make sure that law enforcement has the resources that they need when they are coming into contact with those who have served in the community, as well as we want to look at where the touch points are for service members and veterans as they enter into the justice system, such as going to the commissioner's office, meeting with a public defender, booking and receiving, encouraging those entities within the justice system to have an awareness of the importance of asking the question. We also are looking at best practices that have been established by Trinity and Holy Cross Hospital. They have institutionalized asking the question within their system, and we are going to be looking to bring on a healthcare system to participate in the campaign as well. And I would be remiss to not include state government. We as state employees are coming into contact with thousands upon thousands of consumers every day. So we're working with leaders within the Department of Human Services, Aging and Disabilities to have conversations about what intake looks like when a consumer contacts the Department of Aging, such as Maryland Access Point. Is that question being asked? And do those providers who are asking the question have the resources they need to be able to connect service members, veterans, and their families to resources? We know that we have some champions already in the state, for example, Maryland National Guard, as well as the Maryland State Library System, whom the Maryland Department of Veterans Affairs has had a phenomenal relationship with over the years, and providing resources and information to the SMVF community. And we also want to look to other champions within state government, for example, the MVA. Whenever a customer goes into the MVA to do any sort of dealings with the driver's license or identification card, they are being asked if they have served. So we want to look to these agencies that are already doing this great work and bring them on board as champions. Our goal is to launch the campaign on or around November 11th, being that November 11th is Veterans Day. We are very, very excited and just so thankful for the opportunity to be able to kind of plant the seed, Lieutenant Governor, and with your commission and raise awareness over the work that we're doing to ensure that we are best providing services to this very, very important population. So with that, I will say thank you. And if at any point there are questions, feel free to reach out to Joy or myself. Below is also a link to suicide prevention resources that are available on our website as well. So thank you very much.
Thank you. Are there any questions for Joy or for Dana?
Yeah, Joy, this is Dennis Schrader. I had a quick question. I assume the veteran number includes retirees?
Yes, so veteran, it's specifically to veterans, not those currently serving. So it's the veteran number is just those who have served. But I will say I'll give you a caveat on that, is that the number may not be very accurate, in that when we're looking at our veteran numbers in Maryland for suicide, when they're identified either by they have to be identified either by a family member, a neighbor, or it's obvious in their space that they're found that there's military memorabilia around, that they're a veteran, because it's not like the ME can ask them. So there probably are additional suicides that take place in our state that were veterans, but we don't have a way of knowing that unless they're identified specifically by someone.
And just to piggyback on that, the number 300, approximately 390,000, those are veterans, retirees, as well as those separated before reaching retirement. Maryland's home to about 56,000 military retirees, and that number makes up and is part of that 390,000.
All right. Very good. Well, thank you very much, ladies. Very important work that you're doing, and thank you for that. I'm glad that it's taking place. All right, our next presenters, the path forward for mental health and substance use, John Miller, Chief Executive Officer, MidAtlantic Business Group on Health, and Henry Harbin, National Healthcare Consultant and Maryland Health or Mental Health Advisory member of the board of Maryland board member.
Thank you very much. I hope you all can hear me. This is John Miller. I'm Executive Director of the MidAtlantic Business Group on Health, and thanks so much again for having me and my partner, Henry Harbin, to talk to you today. A little bit of background on the MidAtlantic Business Group. I doubt if any of you have heard of us before. We are a regional coalition of employers, primarily based in Maryland. Marriott in Bethesda, for example, is a member of ours. Legg Mason, now known as Franklin Templeton, in Baltimore is a member of ours, and about 20 others. We have a few members in the DC area, PEPCO, and a mighty member, the U.S. Personnel Department. OPM is a member of ours, so that'll give you a flavor of what kinds of members we have. They're represented by human resource folks who are looking out for the health of their employees and their dependents, also looking to optimize their healthcare spend, and our mission is to help them do both of those things. So that's who we are. My members are acutely aware of the challenges that their employees and dependents face to access high quality mental health care. So they're highly interested in this subject, and as their representative, we are highly interested in the subject. I will also say that if you look at the lower left of that slide, you will see a small logo there that says the National Alliance of Healthcare Purchaser Coalitions. The MidAtlantic Business Group on Health is a member of that organization. More on that on the next slide, and if I can just move over to that, which I think I can, yes. So the National Alliance of Healthcare Purchaser Coalitions is a coalition of organizations like mine across the country. There are roughly 40 of us representing over 45 million employees and dependents collectively. And of that group of coalitions, the MidAtlantic Business Group has been selected as one of 8 regional groups that are promulgating, promoting, driving the path forward for mental health, which is not the primary subject of our discussion today, so I won't talk more about that, only to say that we'd love to come back and talk to you more about the path forward or to answer questions. One of the things that my members, the employer community, is in need of is better information on the connection between mental health and physical health. And to provide that better information, the Path Forward has commissioned a report from the Milliman organization that's been highly instructive to us and highly impactful to us. So to talk about that, I'd like to turn the presentation over to Henry for a few minutes. Henry?
Thank you, John. Can everybody hear me okay?
Yeah.
All right, so the Path Forward did commission this study, as John said, to get better information about the impact of people with mental health and substance abuse disorders on total medical costs. This is, by the way, a 5-year implementation with probably something like 350 of the Fortune 500 companies in the country are involved in supporting this, as well as John's coalition. And these employers have come together because they're really aware of the crisis in mental health care, both in terms of access and efficiency. So, but this report was commissioned. The Milliman company has done several reports on mental health and access issues. One was published last year, and this one came out recently. So they looked at 21 million people's claims over a 1-year period. And the goal was to look at the impact of people with a behavioral disorder on medical costs. So the first step that we did was look at the top 10% of the most expensive patients. Most of that expense, of course, is medical costs, non-behavioral costs. And sure enough, as has been shown in other studies, these 10% of patients basically drove or accounted for 70% of all total healthcare costs in the 21 million people that were studied. So we tried to drill down on that 10%, and it turns out that 57% of the 10% of this high cost group had a mental health or substance abuse disorder. And these were people who were, this was a medical claims review. So it's hard data, but as most people know, if look at medical claims, it's also limited in what you can get. But we did get this data. So this 57%, we looked at what did they account for in total healthcare spending. And it turns out this 57% of the 10%, or 5.7% of the total population of the 21 million people, basically accounted for 44% of all healthcare costs in the total population. The other big finding that is probably not, totally surprising to those of us who track this kind of data and disparities in access is that half of the people that had a behavioral diagnosis had less than $95 a year of specialty treatment. And specialty treatment was defined by either psychiatric drug being prescribed by a primary care doc or a psychiatrist, and any other specialty treatment. So essentially you could say half the group got no treatment, no specialty treatment at all, despite having a diagnosis or being defined or just designated as have one of these disorders. Actually, another 25% of the population had between like $60 and $500 of the specialty behavioral intervention, which is not much. Maybe that would be a few sessions or a few prescriptions of a psych drug. So essentially 75% of the population in this large group had limited behavioral treatment. But the real takeaway, I think, for health policy people, for the state, for Medicaid, commercial insurers, is the fact that this small group, basically less than 6% of the total population, accounted for almost half of all medical spending. So these are people that have both a mental health and substance abuse disorder and a medical disorder. The amount of money being spent on mental health, as you can see, is small. I think it was about, for the whole population, about 4% of the total expenditures for some kind of specialty behavioral treatment. The rest was for healthcare treatment. So I think the policy takeaway here is, one is what can you do about it? But it's also a takeaway, I think, for any state or federal government and any health plan is if you're really not going to pay attention to this subgroup, you're probably not going to have a sizable impact on total medical spending. There are several recommendations that the Path Forward is making, and the Path Forward is both it's a coalition of large employers as purchasers, as well as behavioral health experts. Thank you, John, for moving on to that. This is a kind of a snapshot of the people that are involved. And we had our kickoff meeting here in Maryland, MidAtlantic, that John, we had Howard Half from the State Health Department. We had people from Medicaid. It was really a private sector employer initiative along with the state, which was very helpful to send the same message. So there are 2 or 3 things that we believe that we are pushing for, meaning the Path Forward. One is earlier screening for these illnesses. the adoption of measurement-based care or the use of standardized outcomes tools by either primary care doctors or psychiatrists and psychologists, and to improve the delivery of mental health care in primary care, specifically through the collaborative care model, which has been proven to be effective in improving outcomes, but also has been proven to be effective in lowering total medical costs when implemented. So we're happy that in Maryland, all commercial insurers are now paying the collaborative care. Medicare is paying, and Medicaid started a pilot to start paying for collaborative care, which we were very glad to see. And we are hopeful that Medicaid will see to expand that fairly quickly, as that is one of the big tools that you could use to intervene with this population. So I'll stop there. I know time is limited. We're happy to come back and talk more about this. This is, to my knowledge, been around in the healthcare field for four decades in mental health and substance abuse. And it's the first time there's been a national initiative like this with a multi-stakeholder, with the private sector involved and wanting to ally with government and the rest of the payers, particularly Medicaid. So we're open for questions and whatever people would like. This is just this HR Policy Association is another employer group, along with John Miller's group, that, as it says here, represents 375 of the Fortune 500 companies in the country. And they have, their executive committee has basically stated mental health right now is in the top 3 priorities for them. COVID's made it worse, but we had a massive problem, which I'm sure is why you have this commission. Before COVID, it's just worse now. So thank you for the opportunity to speak, and we're open to questions, John or Rob.
Well, I do want to thank you, and it's quite interesting that the small subset of patients in this study represent 44% of healthcare spend. And I guess it's, as we are looking at, policy decisions with regard to, the cost to the state, which a lot of that is through our Medicaid side of the house. It's making sure that, there is a total cost of care model that we're looking at, is making sure that we understand both the physical needs and the mental health needs of individuals. And I guess, and probably the experts on our commission can speak to this better, that those who are suffering from mental health challenges are probably less likely also to seek physical health benefits until they're at a crisis stage. That's just a guesstimate on my part, but maybe some of the other.
Well, one, Lieutenant Governor, one factor here is that, which is interesting, because I spent 10 years in the DHMH in the Mental Hygiene Administration in the 80s. I was the director of the Mental Hygiene Administration for 3 of those years. And I've been working with Medicaid and Medicaid plans for most of my career. But the biggest group that's impacting this is not the seriously mentally ill. That was less than 1% of the population. The biggest people that are impacting this are people with mild to moderate mental health and substance abuse problems that have comorbid diabetes and heart disease. So a lot of the work that's done in the public mental health system, very appropriately, is taking care of the most severely ill kids and adults. But those services are not necessarily going to help this population. That's why we believe you really have to do something with primary care and earlier screening. I think, as most of the people on this commission probably know, it's an average of about a decade from the time that someone has a symptom of a mental illness and a symptom of a substance abuse problem before these patients are diagnosed and treated. Now, you can imagine if any government sent out a message in the middle of COVID that, well, don't worry, folks, it's going to be about 10 years from the time you start having a fever and cough before we can diagnose and treat you. But that is the current situation for common mental health and substance abuse problems. So I think there are things, policy levers you can pull. This collaborative care is one of them that's got good evidence for it. And I know that's some of the practitioners are using that in Maryland. I think hopefully we could see an expansion of that.
Okay. Any questions from our commission members or comments?
I have a comment. I will just say that certainly this is a huge issue. Our population is definitely aging in place, and so that leads to more of the comorbidity between people with the mental health disorders and the physical disorders. And that's definitely something that we see as a challenge because there aren't any places for them to go. Assisted living doesn't want them. Nursing homes find them to be challenging. And I know there's some work to change that, but it is definitely an issue. And we've been successfully in the last year applying for grants to bring certified nursing assistants and nurses into our program so that we have more support and keep people out of the hospital for the medical issues. Because I will tell you, of all of our hospitalizations, over 60% of them are for medical reasons, not for psychiatric. So it's just a huge challenge that the state's been talking about for years, is finding that balance. And I do find it interesting. To me, this study says, we're not spending very much money on this population. And, I know resources are limited, but somehow we have to balance where the money's going to reach everybody who needs it. And I know that's a huge challenge, obviously.
Well, I think it's a good point. I would say that this population, because it was a commercial insurance, it wasn't Medicare and Medicaid. I think you'd find the same thing, maybe more in Medicaid and Medicare, but the age population was age 2 to 65. So we didn't even include the older crowd. So you can imagine if we included, you're right about having, more serious medical illnesses. I think, the positive part about this is we have an intervention and the intervention doesn't cost that much. And that this is the group, the mild and moderates are the ones you probably would see the most, if treated well. It's not going to be that expensive. It's a series of outpatient things. We're not talking about frequent hospitalizations. And think of the impact you could have on your medical costs.
Again, with my elementary questions. Okay, Senator Eckert, go ahead.
Thank you very much. And thank you, Dr. Harbin and Mr. Miller for that presentation. I think it offers a lot of where we can go in the future. I think that's one of the initiatives that we looked with some of our community rehab programs when we added the possibility of adding nurse practitioner, advanced practice nurses into that mix to be able to handle the comorbidity in diagnosis with folks who do have mental illness. And I've suggested for a long time, we've seen some with the BIP program, but also in getting advanced practice nurses into a primary care practice to be able to get that complete and early diagnosis and intervention and then plan of care in place, I think would greatly reduce even some of the impact on the medical costs. It's a struggle and frustrating to me because we years ago had a pretty robust psychiatric nursing program in the state, and with the going into community care, there just hasn't been kind of clinical opportunity to be able to get that kind of intensive education and clinical experience.
Well, Senator, I would agree. Actually, Maryland and some other states have done a lot to bring better primary care into your community rehab programs for this seriously mentally ill group who have they die earlier than their cohorts, right? It's the reverse side of this. What this model needs is, because there has been some pretty good improvements in that side, but this model is bringing the mental health resources into primary care, not primarily for the SMI, but even though they would get some help, but this would be the other bigger group out there that are driving these costs. But it's really both issues. It's just Maryland and many other states, partly because SAMHSA really encouraged that, was paying attention to bringing better primary care into the nursing and mentally ill population.
I guess I was going back to what I call kind of an elementary. Why is it because we're not diagnosing people early with that are having what you would consider, mild mental health issues? They're not being diagnosed early, that they are overwhelmingly the large spend as far as a percentage of the population Is it that we're just not diagnosing it? They're undiagnosed issues?
I think that is a key part of it, Lieutenant Governor. First of all, the only way screening will occur is in pediatricians' offices, OBGYN, and primary care. It's not going to occur in your specialty behavioral system. It's not going to occur in the employers. It has to be done like every other medical illness, screened routinely as a part of what primary care docs, and I'm counting pediatricians in that group. And they rarely use standardized screening tools for this, okay, for these illnesses. But even on the adult population who've been maybe suffering for this, because there is not, again, routine screening, and there are very simple standardized tools for this in primary care where you might pick these people up earlier. You're not picking them up and you're not treating them early, so when you would be more likely to have the biggest impact for the least amount of money. So it's multifold, I think, but a lot of the focus of the behavioral health advocates, including myself in the past, has been doing better with the specialty behavioral system, better access, and that's great, that's needed. But if you're going to address this problem, you have to do something in the general medical system, and collaborative care and screening are two of the key things.
Would there be a recommendation to those primary care physicians as well as the pediatricians, OBGYN, that they go through, if you do a regular checkup, an annual checkup, that the primary care physician goes through a checklist with the patient?
Yes. I don't know about you, but every time I go see a doctor, non-mental health doctor, I'm filling out symptom checklists, for 10 minutes or 20 minutes as a pretty routine thing. And so adding some of these, depression and anxiety and other tools is not that complicated. That is part of a push by your advanced primary care initiative in Maryland. Howard Haft has been a very key member, by the way, of this coalition. Having the state and the private employers is a very powerful message to providers and to payers. And they are integrating mental health into primary care is one of their key priorities. And so it's just that it does take some time and money for the primary care doctors to do it, which is why this value that we now have a payment code that gives them the money to hire a behavioral health care manager, a consulting psychiatrist, it gives them some administrative costs. So if you would have asked them to do more, Lieutenant Governor, it gives them some resources to do it.
Okay. Yeah, I'm trying to think. I think I did notice some questions, or maybe it was a nurse practitioner or someone asked me in my last checkup, if I was feeling depressed, or, there were some questions that had to do with, I think, my mental health. It could have been because they know I'm an elected official that they were asking me.
Right.
I think I do remember that there were some newer questions that was being asked, but that might be something we could, look at in terms of, even if it's just a checklist. And I think, I don't know, but if the primary care physicians are picking it up, it may not be picked up by the pediatricians, which I'm just guessing, because a lot of parents would be very concerned that you're going to ask this type of question of their child. Parents can sometimes be in denial. It's the kind of thing like, oh, the boy's going to be okay. He's all right. I was quiet when I was young, or I did those things when I was a boy. He's okay. That kind of thing. But it may be something that we could look at as well.
Well, we do know that, pediatricians and other, they, by the way, they prescribe 70% of all the psychiatric drugs, except for some of the atypical antipsychotics, are prescribed by primary care doctors. Even for your seriously mentally ill population, a lot of them, the prescriber of the drugs is not a specialist. So they are involved. I think what we're all looking for is a more systematic adoption of these best practices, so people can count on this as picking it up earlier and doing something about it earlier.
Okay, well, very good.
I have a comment about early screening. We've talked about older people, but we have young people who are in schools where the school nurse And we have several of these pilots, I think, going on right now. I know in Baltimore County, where they're doing what they call SBIRT, which is a way to screen at a young age and be able to identify those kids that are at risk. And then, you know, to be able to start a dialogue with the parents, to be able to do some interventions, you know, maybe it's the the pediatrician. But that's another avenue. I don't know if you're familiar with the SBIRT.
Well, SBIRT is a screening tool for alcohol and drugs in particular, SBIRT. But yeah, there are screening tools that could be done. You know, there's symptom rating scales, and there are ones for kids as well as adults. But you know, primary care docs are busy like everybody else, and part of it is setting the stage for what is a standard. I would add with this that basically, I don't think any non-behavioral medical clinician, nurse practitioner, physician, or otherwise would treat almost any medical illness without using a lab test to constantly measure changes in a quantified way. So could you imagine going to your doctor for diabetes or hypertension and they never measured your blood glucose or your blood pressure? That's essentially what's happening in the treating of depression, et cetera. So this is a big part of the path forward, is getting this greater accountability and screening and early intervention and tracking outcomes better, because it's routine in the rest of medical care, right? So it's not like from a practice point of view, a heavy lift. It may be different, but it's what is done really for other medical problems as a routine basis.
And if I could just jump in on the comment of the pilot programs in schools on behalf of my members, the large purchasers of employers in the state, I love that concept. They relate to me that one of their largest pain points is not necessarily mental health issues in the employees themselves, but rather them having difficulty getting adequate treatment for their children or other dependents. And so, you know, specifically children. So it's delightful to hear that, you know, these steps are being taken on their behalf, because it certainly is needed, and it's a huge pain point for employers throughout the state. So I applaud that.
Yes, and the other piece that
I would like to make a comment, Lieutenant Governor. In our organization, we have adopted a screening tool for all primary care visits using what's called Patient Health Questionnaire 9. An abbreviation is called PHQ-9. It is a very sensitive tool to identify any depressive disorder spectrum, and it is well researched, very easy to fill, and also it has a question related to suicide risk, which is the last question out of the 9 questions. And it is one of the best tools that can be used with ease and without any additional burden on the resources of the primary care delivery system, because patient typically fills the questionnaire assuming they're coming in for a face-to-face visit, or if they are coming into a virtual visit, if there is a mechanism electronically to send them in advance, it can be done. And this tool can be used for any adolescent age 12 or above, 13 and above. And it is not copyrighted, and it is actually developed by the American Psychiatric Association. And it is freely available in every single language that we know of on the web. It is a freely available, not copyright protected tool. PHQ-9.
Yeah, that's one of the common tools. It's a good point. It's used. There are others that are also pretty simple to use and have been validated for other illnesses. And this is it's a practice change. Unfortunately, in the mental health professionals rarely use these tools either. And so when they're treating patients, it's rare. Maybe less than 15% of psychiatrists, psychologists use a rating scale to track outcomes and guide treatment. And we have a study that we can make available to you. We looked at 50 research studies. It showed just the use of these tools improved outcomes between 20 and 60%. So that's a pretty good vote for just adopting a fairly simple technology.
I mean, I can't speak for others, but I want to validate in our organization, Kaiser Permanente, every single patient during a visit, they do complete this. We expect them to
Outstanding.
complete. Yep. And since we are providing virtually care, and since majority of our patients are registered through our online platform, we have a mechanism we can send an email with the tool that the patient can complete on the day or the day before the visit, and we get actually the completed form results that are already in patient's electronic medical chart. So you have it available by the time you're ready to open a virtual visit with the patient.
Good. Okay. Any other questions? Well, thank you, Henry and John. Thank you very much. It was very informative.
Thank
Much
you.
appreciated. Thank you.
Okay. Okay. Before we go to the public testimony, I don't know if we had a chance, whether Heather had a chance to send, there was a one-pager, kind of a summary of assisted outpatient treatment that just as an introduction to people about that. I don't know if that did go out. Maybe Heather can let me know whether she did send that or not. Did anyone receive that?
This is on
It did go
assistant
out, sir.
outpatient.
Oh, okay.
That
Assistant.
went out about an hour before the meeting, I think.
All right.
Yeah, yes.
Okay. You know, one thing that struck me when we were talking about the ACT team approach, and I think it was Dr. Jones had said how typically you utilize it with people who have, you know, had a frequency with the emergency rooms or with law enforcement, that is, as I understand, that's the kind of the target population for the assisted outpatient treatment, and in terms of the way it's been utilized in other states. And so it sounded very similar, you know, from that standpoint. I guess one is more voluntary and the other can be voluntary, but also can be court ordered.
So for ACT teams, in order for a person to be admitted to an ACT team, that requires as an authorization process that you have to go through. In order to meet criteria to be admitted to a team, you have to have had a series of psychiatric inpatient hospitalizations. So you have to be sick enough that you meet criteria for inpatient psychiatric hospitalization repeatedly in order for someone to be able to be referred for that type of intense service. There are other levels of care that people are appropriate for if they don't reach that level of criteria. So whereas with, and also you do have to volunteer. You can't be forced into ACT treatment. That's part of the issue, is because people are coming to you. You have to be okay with people coming to see you wherever it is that you might be, whether you're in a shelter, at home, under a bridge, wherever you are. Once you're a part of the ACT team, the team will go out and find you as best as they can. But you have to be willing to accept the help. Whereas with an AOT, assisted outpatient treatment or outpatient civil commitment, yes, that's an involuntary process. Though when we first rolled out AOT a couple of years ago, the whole process was involuntary, meaning you had to have an inpatient involuntary hospitalization in order to meet criteria to be admitted into that particular program. However, we did that, the legislation changed when it was revised, I think in maybe late 2018, must have been maybe 2018, when it was revised at that time that people could volunteer to be a part of the program. You didn't have to have an involuntary hospitalization. So because it was so hard getting people and the referrals into the AOT program or pilot in Baltimore, the referrals were so low. So AOT is very, very new to the state of Maryland, and it's a different way of thinking about how it is that you care for people who have psychiatric conditions, very different than how people in Maryland conceptualize care. because historically the state has leaned very much on giving people autonomy and allowing people to make their own decisions about their care treatment, care that they are willing to accept and receive. And so it was a real, it's a real mind shift to go from, allowing people to make their own decisions to saying, no, this is what you're going to do. And physicians and psychiatrists, social workers generally don't have the mindset to say that this is what this person is going to do, particularly if that person has not brought any physical harm to themselves or to other people, particularly if they've not done anything to warrant any criminal charges or harm to themselves, such that they don't, if you feel they're capable to make those decisions for themselves. So it's been a very slow getting practitioners to change the way that they conceptualize how to manage the person who requires frequent admissions. That it's been an uphill climb.
Yeah, but it seems as though the person who is, frequently in crisis, where they're in the emergency room, and in many cases they're in the emergency room because law enforcement has brought them to the emergency room. And it's a constant. So when law enforcement brings you, it's involuntary. And, typically it's an involuntary commitment. You're kept in a facility for some period of time until they feel you're stable enough to leave. But if that person is kind of a revolving door, maybe they don't have the capacity to really say, hey, this is the kind of service I want, and they need some kind of oversight. They need some kind of someone checking in on them. Not that you're keeping them in a place. They can still go home, they can still go to wherever they go, but the health department is still there monitoring or checking up on them, similar to the ACT team approach. It's just that it's kind of like you have to, because, and this goes back to that definition of harm to themselves or others. That goes back to that definition.
Yeah, and I was one of the people who certainly was in support of AOT when it came to when the state adopted it. I went to a lot of the stakeholders meetings, listened to a lot of the testimony by the consumer advocates who were very much against it, by state's attorneys who were also very much against it, family members, providers, listened to all of those conversations. But then when we actually were able to move forward with it, and I'm sure you'll hear at some point in time about the project in Baltimore, which was the vendor for that project was Baltimore Core, which was my treatment team, and they did very, very good work with very, very small numbers of patients.
Right.
But that concept of because you still have to have a provider who is I think a lot of it has to do with provider attitudes, because it's the providers who are stating, the clinicians are stating that this person needs this type of care in order to improve in their psychiatric state. The outcomes for the very, very small numbers of people that we saw were good. But the referral, getting the hospitals across the city to refer people was not so good. But the other thing is that when you're talking about people who the police are constantly taking back to the hospital, you have two different categories. You have the people who are coming in because they're intoxicated, and those folks aren't going into a psychiatric unit 9 times out of 10. And then you have the people who are exhibiting, usually some sort of psychotic or manic behavior, who are going to go into an inpatient setting where there's the opportunity to make these AOT referrals, and I think that they need to be made, because I do think that the project works really well when you can get someone in the program.
Right. Yeah. No, I have the report that was issued, and it was very, there was a lot of success. It just didn't have a lot of people, and that's why the SAMHSA funding didn't continue. But I was talking about with regard to law enforcement, where families will call law enforcement because they have an adult family member who is in crisis and they can't control, they are fearful, and it's the police who respond. And if they're, fortunate it doesn't, escalate too far, they will take that person to, a hospital that can, try to address their mental health crisis. And so then they are involuntarily committed. But that same person may cycle through, that there are other times that they come in and they go out, or other issues that pop up with them.
Mm-hmm.
So, I mean, it's just something worth exploring. I know, Carrie, you're familiar with it also.
Yes, I mean, and I think Dr. Jones described it perfectly, and the challenges in Maryland. I mean, Maryland, as she said, is a very individual rights, a pro-individual rights state, and it's a very big culture shift. I can tell you, an administrator in the Montgomery County Behavioral Health Department years ago said to me, she was like, I would never have supported AOT in all the years I've worked in government until I had this job and saw how much money some of these people cost the taxpayers. She's like, I have completely changed my mind about, just to get them the care they need, not because, I mean, yes, some of it was about the money, the bills that she saw crossing her desk, but it was also just about they're not getting the care they need. Their quality of life, I mean, it's certainly not what we would typically say in society is okay. And that's the challenge she said, I never would ever thought I would feel this way. But after I've been in this position, I absolutely have changed my mind. I mean, it is tough. I will say at Cornerstone Montgomery, staff are split on how they feel about it. When we make statements about it, or if we're going to, talk about either side of any bills or any legislation, we probably aren't going to be, testifying as Cornerstone Montgomery staff, because people have very different feelings about it. I'm for it. I think it's a need. I think it's part of the continuum of care that we need to have in place, but it is a challenge for sure. There are some barriers, and it's because Maryland is so pro individual rights, which isn't a bad thing necessarily, but it's a challenge.
So since I work for the Department of Public Safety and Correctional Services, and the Lieutenant Governor brought this, I researched it, and we're one of 3 states that don't have this.
I know.
Personally, I have 45% of my prison population is seriously mentally ill.
Yeah.
So this would prevent people from coming to prison.
Right.
Yeah, no, it's interesting, because when you say that the state is so pro individual rights, I mean, there are other people who will say that there's so many rights that are restricted in Maryland, ranging from our zoning to our regulatory structure. There are a number of issues in Maryland where it's not individual rights, it's more group rights. But in this case, these are individuals that what we're talking about. Now, I know it can get out of hand, but what we're really talking about is those folks who really can't take care of themselves. And it becomes a revolving door. And I know that there are advocates that feel that, kind of starting with the whole deinstitutionalization aspects, that feel that these individuals, can take care of themselves, or they speak a different language. We just don't understand the language. That's kind of the extreme view. But we don't allow, or wouldn't allow, Alzheimer's patients to just wander off.
Correct.
And so,
I think the cycle is that once they get the families or somebody gets hurt, it is corrections. Corrections is the default.
Yeah.
And this would really be a good, it would help reduce the prison population.
There was an article in the Washington Post, and I have it over on my table there. I think it was in the magazine section. This was maybe, it was pre-corona. now we date things pre-coronavirus. It was last year. But this mother was saying that her son, who has been diagnosed with schizophrenia, the only way he's gotten consistent treatment is that he's now at Clifton T. Perkins. He's now basically in jail. You know, basically Clifton T. Perkins is the jail for the mentally ill who've committed crimes. And she said now is the only time he's been able to get consistent care. And it just shouldn't be like that. That shouldn't be the case. And I know folks will, you know, we can all talk about our civil liberties, and, you know, I'm a proponent of that, but these are individuals who really can't care for themselves. And like was just said, you know, there's a tremendous cost associated. And whenever you have to have law enforcement involved in one of these incidents, it escalates the whole situation, because that person who's in crisis may not be responsive to law enforcement. In many cases, they aren't. And law enforcement has to protect their weapon. So if there is any struggle associated with their weapon or whatever, it just really gets out of hand very quickly. And we've heard a lot of stories about those situations that, you know, there just needs to be some way of working with those individuals and some oversight. And I know I sound like a broken record, but I always go back to the woman who was cast out of the University of Maryland Medical on the coldest day of the year a couple of years ago. She clearly could not take care of herself. And even if she was, you know, committed involuntary inpatient commitment, at some point she may have needed that assisted outpatient treatment where there is still some oversight or monitoring of what is going on with her. Otherwise, she's right back or worse. So just, you know, I know the committee is looking at that.
Lieutenant
Senator?
Governor, I just want to say we've worked on this for a long, long time, even before I was a legislator. And one of the things I think is important to keep in mind is that the longer people are not able to respond to treatment, the more damage, the more brain damage there is. And so it breeds to treatment resistance. I really believe that in all the years I've watched folks. I had a young schizophrenic man whose father was in the legislature years before, who was schizophrenic, and he begged me to do the outpatient commitment because he knew that when he did certain behaviors, he couldn't make decisions for himself. And so he really wanted to be able to be sent back to the hospital to his treating physician to be able to have the kind of help that he knew would work when he wasn't able to make those decisions for himself. You know, we've tried advanced directives, mental health advanced directives, outpatient treatment planning, but I truly believe, you know, it's certainly time to be able to revisit this and think it through, because folks need the structure and the support to be able to prevent further deterioration of the brain.
Yeah, okay. And I know Senator Hester, your committee is going to look into that, and I'm going to try to sit in on that briefing with regard to the report, and that's on October 20th to listen in on that. So I know I took time away from the public testimony. So if I can turn now to Dr. Renee Demaris, and I'm probably mispronounced Dr. Renee's name.
No, Lieutenant Governor, you actually got it correct, and most people don't. So congratulations to you for that. Good afternoon, everyone. Lieutenant Governor and Commission members, thank you for the opportunity to provide testimony today. And thank all of you for the hard work you're doing to improve behavioral health treatment in our state. I'm reading this as a prepared statement to make sure we save time. I'm an internist and a cardiologist who's practiced in Salisbury since 1993. I am here today as an individual, although I'm on the board of trustees for MedChi, the Maryland State Medical Society. Today, I'm humbly suggesting that the state's executive and legislative branches explore the possibility of crafting and passing comprehensive behavioral health reform legislation that would encompass many, if not all, the excellent recommendations recently developed by your commission, as well as other similar groups such as the Path Forward that we heard from today. Broad legislation should be considered, I believe, because one, there exists a complex relationship between behavioral health, the social determinants of health, and inequities and biases in the delivery of healthcare. 2, Maryland's behavioral healthcare system is fragmented, underfunded in some regards, and short on facilities and providers in some ways. 3, there's a shortage of inpatient behavioral health beds in Maryland. 4, improved funding for behavioral health facilities and providers would lead to overall cost savings, decreased homelessness, and improved quality of life for those afflicted with mental health disorders. There are many unrealized, well-formulated recommendations for improvement in our behavioral health system from multiple engaged entities such as your commission. The recent pandemic, and 6, the recent pandemic has exposed inadequate surge capacity in statewide behavioral health treatment. Further, I also humbly suggest the funding of a study to examine the feasibility of the creation of additional large comprehensive behavioral health facilities in the state. Recently on the website of Maryland Matters, I had an essay published that elaborated on the potential benefits of new large behavioral health facilities. The essay is entitled Time is Right to Remake Mental Health and Support Systems. Thank you for taking the time to listen. Entertain any questions you might have. Thank you.
Can you submit your recommendations to that email address that was mentioned earlier? MBH, like in Maryland Behavioral Health, .commission@maryland.gov, spelling Maryland all the way out. That would be helpful.
Yes, absolutely. Thank you, Lieutenant Governor.
And when you said large behavioral health facilities, what would you envision with that? What do you mean by that?
Well, I talked about this for a long time, and I'll try to make it as brief as possible. Basically, I would envision fairly large hospitals, 100, 200, 300 beds in certain locations in the state. This would allow us to have potential more research centers around behavioral health, around diseases that we have struggled with. It would potentially revitalize some communities in our state. It would help with inequities and biases in the delivery of healthcare, and probably also help with public safety. Again, I could talk about this for a long time. I would be happy also to send to the website the link to the essay that I wrote in Maryland Matters, which goes over the notion of large behavioral health complex in detail.
Now, there was, people might think I read a whole lot. I don't read as much as I should read, but there was I'm trying to remember where I read the article, and I think I still have a copy of it. There was a column that was in maybe one of the journals a year or two ago, and it had a very, provocative title, but it was, kind of bring back the asylums. But what they were really saying was we could go to, not where we were, locking away people, which was the problem with the old hospitals that we had, but something that is more, smaller, more, community-based, but still facilities that are for, individuals who really, again, can't care for themselves or need the additional care for a longer period of time than what we can currently provide. And, not talking about probably as large a facility as what you were talking about, but facilities for individuals that, can get longer term care than what is currently available to individuals. So I'm not sure how that would work, but
well, I think that's also an excellent idea. As I said, I'm an internist and a cardiologist. I see a lot of the patients who have these problems sort of by the way. I'm seeing them for some other reason, and here they are with all these other issues. Whether it's a couple large behavioral health hospitals or several across the state, smarter people that know more about this than I do would be better to be able to answer that question. And that would be something I think could be addressed in such a study to look at the feasibility of this. Perhaps we do say that, we need these spread out more across the state in smaller facilities.
Okay. All right. Any questions for Mr. DeMaurice, excuse me?
Damaris.
Damaris.
Yeah.
Okay, see, I got it wrong.
You got it right the first time.
I got it right the first time, but the second time wrong. Okay. All right, well, thank you, sir.
Thank you very much for listening.
Okay. We have another public testimony signed up, Adrian, and I can't necessarily recognize how it was written on my page. Bree?
I'm happy to go ahead. Can you all hear me?
Yes, can you please state your name for us?
Good afternoon, Adrian Bridenstine. I'm with Behavioral Health System Baltimore. Thank you, Lieutenant Governor Rutherford and members of the commission for hearing my testimony today. Just wanted to quickly comment on AOT. And as you've heard from the discussion today, it's a very controversial topic. The idea of legally mandated treatment or forced treatment, as you've heard, is we've gone back and forth with this in the state of Maryland and have landed on an approach that my organization, Behavioral Health System Baltimore, has a responsibility with overseeing and implementing in Maryland, and that's the OCC pilot program that you've heard about today. What we know is that the forced treatment doesn't necessarily result in better health outcomes for this population. And a part of the conversation I think was missing, or a part of the puzzle that I think was missing from today's conversation, is how much social determinants of health play a role in a person's ability to succeed in an OCC program, whether it's of a pilot program that we have in Maryland or of one that uses more of the civil legal system to mandate that type of treatment. And those are things like housing and public safety and how those can support someone's overall recovery. So I'm looking forward to Senator Hester, your committee's looking at this in a deeper way, and I look forward to being part of that conversation, but would encourage you to make sure that you're considering how social determinants of health support someone's overall recovery. Again, whether it's in a more legally mandated program or if it's one like that we have in the state of Maryland. We do think that the one that we have in a pilot program is working. You've heard a little bit of that from Dr. Jones today. I think she did a great job summarizing it. What makes Maryland's unique is that it holds our system accountable to the person, whereas other states are holding the person accountable for their own treatment. And that's really important when you're working with people with severe mental illnesses, comorbidities, and also have all of these other complex social determinants of health challenges. We're able to do this accountability piece, by having the OCC pilot sit within the local behavioral health authority in Baltimore City. It is our role to oversee that system of care and ensure that that accountability is here. So again, I look forward to future conversations, but would encourage you to take a good look at what we have here in the state of Maryland and build upon the strengths of the current pilot program. Thank you, and happy to entertain any questions.
Okay, well, thank you. Yeah, well, I think we have an opportunity to look at those existing programs, and I guess there's, and maybe it's just my lack of knowledge that I guess and I guess you can say AOT is forced treatment, but so is involuntary commitment. At least in this way, it appears to me that it can be formulated that it's oversight more so than, forcing that you have to do certain things, and the person
Least restrictive. Least restrictive.
It's
the
least
restrictive.
Yeah, and the person at least has some freedom. They're not kept in a facility against their will. So, but that's something that's worth exploring, and I think those types of discussions need to be had. We need to, look at all what we can do to address those folks who are really having challenges, and those families that have adult family members that they really have difficulty getting long-term care for them. And so that's, and perhaps it's through the current process that you have, the current pilot, or maybe it's something else. So thank you. Yeah. Any questions?
Lieutenant Governor, I just wanted to jump in and say that I am aware that this is a controversial subject, and I think it's really important that we hear both from our experience here in Maryland, but also maybe from some other states with slightly different approaches.
Yeah.
And I'll put in my chat box my public email address so you guys can Google it. But if you're interested in joining us, I just ask that you give our office a heads up, and we'll make sure to start a list of people who want to comment on this topic. And I look forward to learning more. Thank you.
Thank you. And again, as I said, we should not shy away from controversial subjects. We just need to, explore what's going to be best for, the population that we're trying to address. And so there are going to be different views, and maybe we can come to some point that it's not all or nothing one way or the other, but, with the intent of trying to address the individuals that are having these challenges, and they don't have to wind up in, the correctional facilities, which seems to happen now, be it at the state level or the local correctional facilities that are filled with individuals that have these types of issues, along with, in many cases, co-occurring with substance use disorder. And so that's something we all would like to see avoided. I didn't have anyone else signed up as public testimony. Is there anyone on this line, on this call, that would like to make a comment now? Okay, well, hearing no one else jumping in, Dr. Jones has a visitor there, I think, that wants to participate. Our next virtual meeting is scheduled for November 5th, and that'll be from 4 to 6. And again, I want to thank everyone, for being involved and participating. And when we get to the November 5th, I think at that point we'll be looking at, putting together a draft report and recommendations to send out to everyone, so we can finalize between that time and the end of the year. So with that said, again, I want to mention to those who are who either have testified or would like to submit comments, they can send them to mbh.commission@maryland.gov. So again, thanks everyone.
Thank you.
Thank you.
Thank you.
Thank you. Good night.